Hey, thanks so much for joining us today. This is Ted Johnson here at GM Insights. We're so glad to have Dr. Chad Hales join us today. He is an associate professor of neurology. He's a physician scientist. He's very active in clinic and active in research. And he is a thought leader. And so we're so glad to have him on today. If we have difficult cases, we go to Dr. Hales. And so deeply appreciate him coming on today. And we'll walk you through a couple of slides before he starts his presentation. Emma, next slide. Great. And we have taken a look at the slides and attested that the conflicts of interest are not sufficient to make any other changes. So you're in for a treat to hear Dr. Hales, and we'll take down our slides and let him upload his. At the end of the presentation, we'll show you some more information about how you can get credit for this. And I believe, Emma, that the session today is 18062. Is that correct? So if you've already registered for CME credit from Emory Office of Continuing Medical Education, you just text that code of 18062. We'll put that in the chat later. This is National Alzheimer's Disease Awareness Month here in November. That's why I'm wearing purple. If you thought, didn't that just happen in June? That's actually Alzheimer's and Brain Awareness Month. So why not have 2 months? And so, Chad, we'll take down our slides and let you go ahead with yours.
Sounds good.
Feel free to put questions in the chat. I'll be monitoring the chat while this goes on. And over to you, Dr. Hales.
All right. Thank you guys for having me today. Hopefully the sound is okay. Let me know if there's something that pops up in the chat that I need to address throughout. I can try to do so, but we'll also save a little bit of time for questions at the end as well. So, all right. So let's get started. So diagnosing Alzheimer's disease with plasma tau, is it a good idea? So our learning objectives will cover, they're pretty straightforward, I think. The first will be just to introduce, well, what is plasma tau? Are these new blood-based biomarkers that you've been seeing about in the news or hearing patients chatting about? How does it compare to other Alzheimer's disease biomarkers? And I'll remind you of what we consider to be confirmatory biomarkers for Alzheimer's disease. And then put that in context with the plasma tau or the tau blood test. And then finally, we'll have a brief discussion about which patients should have this particular test or that you should consider doing this test on. So, what is plasma tau? Well, to start with plasma tau, you got to start with the brain, right? And what I'm showing you here is a coronal section of MRI. Arrows are pointing at some hippocampal atrophy. So in the right clinical context, this patient might have Alzheimer's disease since AD can affect the hippocampus. We know that Alzheimer's disease has several main pathologies. One is neurofibrillary tangles, which are these aggregates of tau protein, TAU, that accumulate inside of neurons. There's also some floating around in the tissue. And just to take you way back, so what does phospho-tau or plasma tau actually mean? And so you have to actually look down at the structure of tau, the protein, and you may recall that tau has lots of different domains and lots of different places where you can drop a phosphate group. Now I'm going to give you all you guys probably some post-traumatic stress disorder if I bring up the concept of organic chemistry and chemistry molecules, but you can see I have a phosphate group that I'm showing you here. And in general, we're going to be focusing on the phospho-tau 217. Okay, so as you know, serine and threonine amino acids can be phosphorylated, and this is just one, as you can see, of many phosphoepitopes across the tau protein. So you got this phosphorylated 217 epitope. How do you look for it? Well, you got to draw some blood, right? Go to the lab, draw some blood. You got to take that blood, put it in a centrifuge, spin it down, and it gives you a tube. And that gives you the plasma, right? It separates the blood products into your blood cells, some white cells, etc., and then the plasma up top. And of course, the plasma is what has our p-tau 217 or tau fragments in it. Okay. So this is the nuts and bolts of where plasma tau comes from. I'm skipping over a lot of stuff, as in how does it get from the brain into the blood, and that type of thing. We're not going to go into that today, but the bottom line is there is some tau protein in the blood. Some of that tau has phosphate groups on the 217 threonine. In this test that we're going to use, there are a couple of different platforms out there, which I'm not going to specifically address those platforms, but they quantify the amount of phospho-tau 217 in the blood. And if we're talking really small quantities, so picograms per microliter, okay, or per ml, very small amounts. And so that's why it's actually taken so long to get to this point of having a blood test, is because you got to have assays that are sensitive enough and reliable or precise enough to give you reasonable metrics. So how does this compare to other Alzheimer's disease biomarkers? So in the Alzheimer's disease space, lots of things can be considered as a biomarker, right? That could be a neuropsychological testing that shows that you have memory impairments on some of the memory tests. Maybe it's that brain MRI that I just showed you that has hippocampal atrophy. Perhaps it's that clinical history of the repeating questions and gradual progressive cognitive decline over 2 to 3 years. So biomarkers, anything that's going to help you label what the disease is. And at least for Alzheimer's disease, we think of 2 biomarkers as being confirmatory for Alzheimer's disease. Of course, in the past, we've talked about, well, how can you confirm Alzheimer's disease? And of course, early on, it was, well, you have to look at a piece of brain under the microscope. But we're a little bit past that now. We're able to use things in living people and identify Alzheimer's disease. One of those is a spinal fluid study, showing you an example here. Lumbar puncture, we measure 3 different proteins. You'll see that one of those is phospho-tau in the spinal fluid. And these little arrows here are just indicators of, well, what happens to those values in the spinal fluid in Alzheimer's disease. And A beta actually goes down in the spinal fluid of patients who have Alzheimer's disease, and the 2 tau values go up. I won't get into the intricacies of which tau this is. Usually it's p-tau 181. These are often reported as ratios, such as amyloid to tau indices. But the bottom line is this spinal fluid is considered a confirmatory biomarker for Alzheimer's disease if you've got the right clinical history, the right profile of measures in the spinal fluid. The other is amyloid PET, which has its own challenges, right? Amyloid PET is this special brain imaging where you have an IV placed, injected with a little radiolabeled ligand that binds to amyloid in the brain. And if you have Alzheimer's disease changes in your brain, particularly amyloid, then it binds to that and it creates this picture like what you see down here on the bottom. And I'm showing you negative and positive scans just to kind of enrich your day, right? You can see what it looks like if it's a negative scan, kind of has this little spindly white matter looking appearance to it. And then when you look at those that have the positive scan, it's got all this radio tracer uptake that goes all the way out to the surface of the brain. And you can look at it in 2 different views where the radio tracer is white, or you can invert it where it's black, and that can give you different pictures. I show you 2 really good examples of a very negative scan and a very positive scan here, but they are sometimes more difficult than that to interpret. There are ways to quantify the amount of radio tracer uptake, and this is not meant to be an amyloid PET discussion, but there are ways to quantify that which may help with interpretation as we move forward. And so just kind of keeping that in mind. But not to distract from the point at hand, 2 confirmatory biomarkers for Alzheimer's disease that we use now in clinical space: spinal fluid testing and amyloid PET. So how does that compare to phospho-tau 217 or plasma tau assays in general? And are we at a stage yet where these types of plasma assays could potentially replace the spinal fluid or the amyloid PET? And the answer to that second question, at least for now, is not yet. But let's walk you through some of the data. So let's just focus on these top panels first. The bottom line with this figure is it shows you some associations between amyloid PET and tau PET imaging with multiple CSF and plasma profiles across several different cohorts. So you can kind of look at any of them. The bottom line is they're all pretty similar. So let's just focus on this one side over here. And the bottom line is you're looking at sensitivity and specificity as compared to a positive amyloid PET scan. And what you can see in these assays is that the closer you get to the y-axis, the closer you are to 1, so the better your specificity and ability to rule out disease. And then the sensitivity, the higher you get and the closer you get towards 1, the better your ability to identify the disease in those patients that actually have a positive amyloid PET scan or amyloid in their brain. And what you can see is that this black line, the light blue line, and the red line, those are several different assays. One is an A-beta ratio, one is a spinal fluid, tau to A beta ratio, and the other is plasma tau 217. And you'll see that the number that we often report here is the area under the curve. So the ability, that's your kind of sensitivity measure, your ability to feel confident that it's correlating or predicting that the patient may be amyloid positive. And what you can see is all of those they're tracking right along with one another. Plasma and spinal fluid and high sensitivity specificity with amyloid PET. And that's really I'm just showing you one publication here, but there are multiple that are out there. There are lots of different plasma assays, and I'll show you an example of that in a moment. But the take home is that in most of these cohorts, there's a very good and close association between these plasma tau assays and the spinal fluid assays and your amyloid PET. There are some nuances to this, which when you dive down into the data, there are some that seem to perform better than others, and I don't have time to go into that today, so I'm not. Here's another way to display data, and so just to orient you to this figure, this is taking multiple plasma and tau as well as other markers, so GFAP, glial fibrillary acidic protein, neurofilament light chain, some other ratios down here. And this is a heat map where it's correlating those individual assays with all the other assays to say, well, how well do these all kind of cross-correlate with one another? And this is multiple assays, multiple platforms. I'm not endorsing any one particular assay or any one particular platform, but just showing you the data. And of course, the way you read this is, for example, if you look at this assay here, the plasma tau percentage, and you compare it to that same assay, it's got a black spot there because they're obviously going to correlate, right? It's the same value. But when you kind of step aside and look at what's running alongside those numbers, that's where you start to see the correlations with the other assays. And you can see that those correlations are pretty good with the other assays. So for example, this ALTS path seems to correlate pretty well with this C2N plasma tau 217. Similarly with this Fujira Bio, which is one of the platforms for measuring p-tau 217, similarly correlates very well with the ALTS path p-tau 217. And so this is really just meant to show you that there are lots of assays out there, and these p-tau 217 assays, they all seem to kind of correlate pretty well in the clinical realm. Now, it also shows you how well these are correlating with one another, but also, in some cases, how poorly they correlate with some of these other measures, such as neurofilament light chain, GFAP, etc. And that speaks to why the p-tau assays are performing better, right? Because we know that these other markers of disease, they may represent inflammation, but they don't give you that sensitivity, specificity numbers that you really need to make an Alzheimer's diagnosis. Showing you this, kind of drilling down on two specific assays. This is an ALTS path assay for p-tau 217 and a LumiPulse assay. Again, these are platforms. I'm not going into the platforms of how these tests are done, but it's showing you something very similar. When you compare how well their sensitivity and specificity is with one another, it's pretty good, right? I mean, they're all running up there pretty high. When you look at the area under the curve for all of these, they're all quite high. Sensitivity and specificity varies depending on the assay and, importantly, depending on the cut points that you have for individual assays. And I'll tell you what I mean by that when I pop in my next slide over here. For example, if you just take these assays and you just did a single cut point, below that cut point is a negative assay, above that cut point is a positive assay. These are your sensitivities and specificities. So, for example, if you take this Lumipulse p-tau217, you have a cut point of 0.229 picogram per ml, and you go above that cut point as Alzheimer's, and below it is negative. This is your sensitivity and specificity. And you might say, well, high 80s, that's not bad when you start talking about diagnostics. But is that good enough for diagnostics to put somebody on a therapy that may have side effects? And is that good enough to convince and feel confident that your patient has Alzheimer's disease? And so that's what kind of led to this concept of setting 2 cut points. And so what I'm going to show you, let me orient you to this figure. This is comparing these two assays again, but showing you more data. And so let's focus over here on these panels on the left first. To orient you, up at the top, you've got this is the Lumipulse assay looking at the probability of amyloid positive test. And of course, the green is the amyloid was negative, the amyloid PET was negative. The red is the amyloid PET was positive. Okay. And then this is looking at that kind of value of the overlap of the p-tau217. More importantly, if you focus on this bottom panel, this shows you where those cut points are based on the picogram per ml. You remember over here on this figure, I said if you create a single cut point of 0.229, it gives you that 88, 80, 86, 88 sensitivity specificity. But if you create a lower cut point of 0.185 and an upper cut point of 0.324, and then you stratify in this data set, which is around 400 subjects, you stratify it based on their amyloid PET, you can see that these numbers they start to look a lot better. And most of these people who have a negative plasma tau are falling below this dotted line, which is kind of considered the threshold above which you would have a positive amyloid PET scan. And over here on the right-hand side, if you have a value that's above 0.324, that you're going above that dotted line, which would suggest that you have a positive amyloid PET scan. Now you might say, well, what about all these people in the middle, these gray zone people? And what this and this shows you is that there is some overlap in that range between the lower and the upper cutoffs, where the test doesn't do a good job of discerning who has a positive PET and who doesn't. And the test just recognizes that up front and says, we're not sure. So if you fall in that indeterminate range, you may be positive or you may be negative, but we're not sure. And the only way you can really figure that out is confirmatory study on the other side, right? Doing the amyloid PET or doing the spinal fluid testing. But what this gives you is these 2 cut points really helps that bump up that sensitivity and that specificity. And that gets you up into the 90s, right? With the sensitivity and specificity, which is on par, if not in some cases better than the spinal fluid. So this is pretty exciting, right? You've got these assays that are able to predict amyloid positivity or negativity in patients. There are lots of nuances in here that I don't have time to go into. Some of it is, well, how do you decide if the amyloid PET scan is positive or not? And I glossed over this, but there's this concept of a centiloid value, which is the actual radiographic quantitation of how much of that ligand gets taken up into the brain if you do an amyloid PET scan on a patient. And above 25, at least in these results, was considered amyloid positive and negative. This is pretty stringent to drop it down to 25. And all-inclusive, right, as you think about amyloid positivity. Some assays might set that bar a little bit higher. Some might set a little bit lower. But the bottom line is that you can see that you've got these 2 different patient populations, and they seem to be stratifying quite well based on the p-tau. All right, so one last slide before we address a couple of questions. So what I've shown you thus far is that we've got confirmatory biomarkers, spinal fluid studies, amyloid PET scan, which can be used to confirm underlying Alzheimer's disease. I've shown you that the plasma tau assays, if you set the assay up correctly with the right cut points, you can get really close sensitivity and specificity wise to those spinal fluid and amyloid PET values, which provide you with high level of confidence about the underlying diagnosis. Okay, so now who should you use this in? I don't want you to take this for this is absolutely the right way to do this, because I'm still trying to refine who I use this in. This is very new. This is a new test in the clinical setting. So take this for what it's worth. At least for now, I see this as number one, being helpful for patients and families who are looking for diagnostic clarity, but maybe a little bit too impaired or with exclusions for amyloid monoclonals. And so in those cases, that test, if it comes back as negative or positive, you can say, this Alzheimer's may be contributing, Alzheimer's may not be contributing. The caveat is if it's in that indeterminate range, you need to be very clear that this doesn't mean that we're going to go on to another confirmatory study. This is just, if it gives us some answers, great. If it doesn't, we're going to stick with the clinical assessment at this point. We're not going to, test until we can't test anymore on this. So that's one way I've been using this. The other is in patients with cognitive symptoms and objective impairments on standardized measures that would at least support a diagnosis of mild cognitive impairment. It also helps to have an underlying suspicion of Alzheimer's disease, right? Because you are really trying to refine your ability to identify patients who, at least in my mind, may benefit from novel therapies, clinical trials, etc. And is there a way that we can screen them quicker to maybe get them to a confirmatory study faster? And I've used it in that way in several patients where this clinical syndrome looks consistent with Alzheimer's disease. I'm trying to decide, do I need to work this patient in for a lumbar puncture sooner rather than later or not? And I say, all right, we're going to figure this out now. We're going to do this study, and if it's positive or indeterminate, that means we need to work a little bit harder to get this patient on to the next step. And so I found it useful in that way. Now this last one, I'll let you read it first, and then I might see some of you with some consternation on your face. So, patients who are worried about their chance of developing Alzheimer's disease due to known ApoE status or family history. Had one of these in clinic yesterday. The answer is no, this is not the place to use, for now, to use the plasma tau assays. And the main reason being is we don't have downstream intervention or therapies yet. We don't know that starting amyloid monoclonals before people develop symptoms will benefit. There are clinical trials ongoing currently that will result 2028, 2029 that will help inform us as to whether using or screening earlier would be better and would be helpful. So for now, play the note card. I don't know if anybody has seen the game Exploding Kittens. I don't have anything against cats, but that's just the name of the game. But in that game, you've got these different moves you can do, and I'm playing the note card on this one. You can look that up. So we've kind of gone through a couple things here, right? Showed you about the plasma tau assay itself, what you're measuring in the blood, kind of how it compares, and then, can it be used as a screening tool in the clinical setting, but also being very clear that we haven't fully, refined how helpful this is going to be at expediting workup for patients. One of the figures I did not show you, which deals with predictive models of what happens if you have lots of people who start using these plasma tau assays in patients who have symptoms, and you identify all those that have a positive assay. The challenge is if you do that, even across the primary care setting, then all of a sudden you've got a whole lot of people and a bottleneck at the other side of, well, what do you do with that group of people and getting them to that next step? And that's certainly something for us to try to continue to sort out on the COG clinic and the neurology side, but this is more of a systemic issue, right? Due to just the sheer number of patients that might benefit. Now, you have to juxtapose this with information and transparency. Some patients and families are like, I don't care if I have symptoms or not. I just want to know, do I have some amyloid in my brain and do I need to do something about it at this point? And you're going to have people try to twist your arm to order these different studies. And I'll have to let you be the judge as to how far you go with that. But just the cautionary tale is had a patient who got genetic testing one time at one point because they had a family history of an autosomal dominant condition, and they got testing because they thought they would be negative, but they weren't. And so you have to also place that piece in context with this. The other is that we've already sort of seen what happens when you start to put this information in the private sector or the public sector with 23andMe and the reporting of ApoE4, right? E4 increases your risk for AD doesn't mean you have AD. And this is one step further, right? This is showing you have likely increased risk if you have amyloid in your brain, and it means that, yeah, you're probably going to develop Alzheimer's at some point. I just don't know when. And so there are a lot of different ethical challenges in here and nuances, and I think we're going to sort it out as we move forward together. So I'll stop there.
Hey, thanks, Chad. Really appreciate it. We set a new attendance record, so that's awesome. So thank you so much for that. And I looked up that 1,000 micrograms in a milligram and 1,000 nanograms in a microgram and 1,000 picograms in a nanogram are about 1 billion picograms in a milligram. So if you're thinking about how small these amounts are, that gives you some picture of it. I wrote down that these tests might be good enough, depending on ordering the right one, and depending upon how you use it as a confirmatory test in a certain clinical setting. And I hope that kind of summarizes kind of where you got. We have 4 really great questions up in the chat. If you can open your chat and find them.
Yep, I got it.
Start with Dr. Kolshrestha, Dr. Cohen, Dr. Patton, and Dr. Ashish.
Yep. So the first question here looks like speak a little bit to the cutoff values in patients with other conditions, higher BMI, CKD, CVD. Great question. How does race impact these as well? We know that in the spinal fluid that p-tau levels are a little bit lower in African Americans versus white people. So yes, there are some challenges here with those values. Those actual issues weren't correlated in these data sets that I have, but definitely something to look into. Dr. Cohen asked, it's hard to understand why p-tau reflects amyloid status, and thank you for bringing up. Excellent point. The level of phospho-tau in the blood is not to be used to indicate the level of tau in the brain. The correlation is with amyloid PET. And it's just the way the assay was designed and the way they did the correlational studies. That's just the bottom line. The CSF tau may be a little bit easier to do linear correlations as you have changes in tau levels, say to monitor for therapeutic efficacy, but it's not clear that these plasma tau assays will be useful for that yet. The next question was acetylcholinesterase inhibitors shouldn't cause an issue that I'm aware of in changing the p-tau value. And then the possibility of p-tau elevation to other conditions. Yes. So that's a very good question. And so you may have, head injury or stroke or epilepsy or, things that aren't Alzheimer's disease, frontotemporal dementia, progressive supranuclear palsy. And, a lot of these studies were done in a slightly biased sample, right? Patients who with suspicion of Alzheimer's disease and amyloid PET. So I do suspect there will be some overlap, and I even have some anecdotes of that. But the important piece here, you are clinicians. You have to use the clinical history in context with all this other stuff. This is just another little tool in your tool belt along with the MRI and the neuropsych testing and all these other things that you are using to help come up with a diagnosis for your patient. And so if you've got a patient that was negative or borderline on this p-tau, but you are pretty sure they have Alzheimer's based on everything else, that's why you go to the confirmatory study. And I've seen it go both ways. I've had a negative p-tau. I actually haven't seen it go both ways badly yet. I've had a negative p-tau that was confirmed negative by an amyloid PET. I have heard some anecdotes from other people using these assays who have seen mismatches, negative p-tau, positive PET, and vice versa. So there are some variability in these assays. Does it correlate with tau PET scans? Yeah, that was one of the figures I kind of glossed over there. I apologize. Maybe slide 5. Their tau PET was also on there, and it does seem to correlate pretty well with tau PET as well.
So we're working on getting the evaluation link set up. Emma, if you could maybe show the QR code for folks who are getting credit for this session from the Emory CME office. Put back the session number. It's 18062. And if you go in and text it to the Emory CME number, which I encourage you to write in your phone as a contact Emory CME office, you just put attend 18062. Chad, there were just a couple of other questions that came in late. If you could find those, and I know that some people have signed off and needed to sign off, but
Yeah. I see the one there on is when do you expect it to be widely available clinically? I think it depends on where you are. It's available in the Emory system now. You can look it up in Epic and you can order it. And it's not restricted use to anybody, but it does come with those caveats that I mentioned. As far as other assays throughout the community, it really depends on who has accessed your practice and what you may have available in your system. There are several that are out there by Quest and other companies.
we do have a list of people who attended today. We'll get an active link out to them. I'm sorry, we've got both the QR code and the link going to an inactive site, and so we'll work on that. And then thanks so much for joining us today. Again, Chad, thanks so much. Really appreciate you. This was we were trying to hit 70. We only got to 69, and then we go to 68, and then we go to 69. But broke live attendance records. For those of you who have friends who couldn't make it today, let them know that all of our talks for the GM Insights series are on YouTube. And if you just look up YouTube GM Insights playlist, it'll actually take you to that. All right. Hey, thanks so much, everybody. And Chad, people are saying that there were two people watching under one name, and so you actually did break 70. And so I appreciate the collegiality and folks fessing up that more than one person is watching at a time. Thank you. Look at that, Allison. Look at that. See? Ta-da. All right, perfect. Okay, thanks so much. Talk to you later. Have a great day.
Thank you.